Hello, this is Bob Dennis and my colleague Stacey Ravid, and she and I both have PhDs, and she's a nurse, and I am not a clinical person. I do mostly engineering and basic biological research, and we work together on PEMF and issues related to pain and opioid abuse and things like that. And we're starting here, this is our first one, a sort of free-form video to discuss a scientific paper that relates to the use of PEMF for pain. And so this time Stacey picked the paper. We're going to talk about it, and we're going to answer some questions. And if you had some questions about it, you can put them in. We're going to post this on YouTube, so you can put them in below the video, and we'll try to answer those as well. But we have a few questions from colleagues and so forth. So what I'm going to do now is I'm going to screen share the paper that we're going to talk about. And this is going to be like when you're in graduate school, one of the things you do working on a master's degree or a PhD is you can have a journal club where you just read a paper and you talk about it. And you try to gain insight into what's going on. So we're going to try to gain insight into this paper. We're not just going to report the results, we're going to think about it. And so since Stacey picked this paper, maybe you could tell me why.
Yes, my dissertation topic was solutions for the opioid epidemic, holistic modalities for pain relief, and I selected the micropulse PEMF for pain relief. So this is a topic that I have studied, and I've read a lot of articles. I picked this one mainly because of low back pain. Many people I know are dealing with low back pain, and especially right now during COVID, there's been a lot of people that are sitting more than usual, watching more Netflix and TV. So I chose this predominantly because of the low back pain, and it was pulsed electromagnetic field therapy for low back pain.
Excellent, and I think it's an excellent article. So I'd kind of like to, since I've given a lot of journal clubs with my students, because I've had a PhD now for 25 years, and I've had many doctoral students and run many journal clubs. I'll just sort of start, and then we can go back and forth, and you can start talking and commenting anytime if you'd like to, Stacey, and I'll just go through this like I would with graduate students. Part of a scientific paper is understanding what you're reading. Right. So the first thing you look at, can you see where my mouse is? It's pointing.
Yes.
I think I'll turn off the highlighter for now. The journal name is Pain Therapy or Pain Therapeutics. This was published in 2019, and it tells you the volume published that year. So this is volume 8. So they obviously published a lot, and which pages it's on. So that tells you where it is. And then below it is a link, just a pointer URL, and that gives you the location of the paper if you want to download it. This is open access, so you can find this paper. Easy way to find it is just type in the name of the title of the paper and Google search it, and it'll come right up, take you to the page, and you can download this yourself. Now look at the authors. A good thing to do with a paper is look at the authors. And the order of authors in a scientific paper is really kind of important. The first author is usually the person who did most of the work, and very often that's a postdoc or a graduate student. The last author is usually called the senior author. In this case, it would be Anthony or Onorato, all right? So that's probably the person who organized the study and did this. This is not hard and fast, but it's usually the first and last authors that are the most important. The one that turns out to always be the most important author is the one that's called the corresponding author. That's the author that you write to if you have a question about this paper. And I think it might, in this case, be Anthony J. Lisi. So he might be both the first and corresponding author. And usually somewhere in the first page right here will tell you where to who to contact. And it's clearly Anthony J. Lisi. And that little mail icon means that's the corresponding author. And that's why they give, for Anthony Lisi, they give his email. So that person is both the first author, which, like I said, could be a grad student, but in this case, it's the main person who wrote this paper and the main person who you'd ask questions to about it. So by far, Anthony J. Lisi is the most important author. And that matters because then you'll start to see that person on a lot of similar papers usually. And Along with them will be their clinical colleagues and a lot of their students and their technicians, right? The people in the middle on a paper are usually people who do the sort of the in the trenches work on a paper. Just, all the things you have to do, like taking data, talking to patients and things like that, right? So this also tells you when the paper was submitted in October 2018. And it took, took in this case about 5, 6, 7 months for it to actually get published because it's peer reviewed, right? So now you have a sense for, what you're looking at. We haven't even gone into the paper yet, right? And if you want to find more papers like this, you can just search this person's name, the main author, and you will, on Google Scholar, you'll almost certainly find many other similar papers.
Mhm.
So any questions at that point, Stacey?
No, not at all.
Okay, so that's, I know you know all this. I know all this. We've all had PhDs, they have to go through this. But for a lot of people reading scientific papers, they kind of don't know where to start. And where you start is, okay, who are the authors? What's the title? And, sometimes the title of a paper doesn't actually match what's in the paper. That's really weird, but it's true. And then you can scroll down on the first page and look at what their affiliations are, right? So here, the first author, Anthony Lisi, is in Bridgeport, Connecticut. Other people are in Tel Aviv, in Israel, right? So basically, most people read through an abstract. And here's a fun fact. On average, how many times does a scientific paper get read by someone else, not associated with the paper? How many times does it get read by someone front to back? A typical scientific paper. The answer is 10.
Oh, I was going to say 9.
10 in the entire world. So people keep talking about the importance of peer-reviewed literature and how important it is to run a study or something. But most people just look at the title and they look at the abstract. But when they actually study this, reading a paper, cover to cover, very few people do. And that number.
Bob?
Well, because a lot of people have gotten pretty cynical about academic science, and a lot of it's not reproducible. We'll talk about that. And also, academicians, being an academician myself at a university, and I know you teach as well, but a lot of academicians have become not really relevant to average people. They don't really give you answers of things that really matter. And like in the world of economics, for example, a few decades ago, about 30% of all national level, international finance and economic decisions, they had input from an academic economist, about 30%. And nowadays it's 0.3%. So 99% of the input that had been given by economists to people in academia, 99% no longer there. So academics, university academics, are becoming much, much, much diminishingly important in the world of big, important decisions. This is true in medicine. This is true in, economics. This is true in everything except for things like astronomy and physics that are just purely scientific. Have a whole lot of public policy, but when you're dealing with medicine or public policy, the impact of academic people is very low, and it's increasing year by year. So
I just want to make one comment. What's astonishing about that, the average of only 10 people reading these articles, if people knew how much time and energy goes into these studies and then writing the articles, it's incredible. And I'm just stunned to find out that the number's 10.
Right. So the joke that I give is that my son, who likes to play different games, so on a computer, and he has about 68 people following him on YouTube. When he records himself playing Minecraft, he has about 6 to 7 times globally the impact of a professor writing a paper. I mean, that's the reality we live in, is that kids posting unboxing videos or videos of them playing Fortnite are actually influencing more people than a scholar, right, with a paper.
let people know it's one of the reasons that we're doing this is to help bring attention to these studies and these articles. They're very valuable and we need them to not be obsolete, and we need more than 9 people to read these articles.
Well, what you're saying is absolutely true. And so, Stacey, as you pointed out earlier, these things are really hard to do.
Mm-hmm.
And if they're done correctly, I think this one was done pretty well. If they're done correctly, they're really, really valuable. And most people, if you ask them, they would say they're valuable. But in practice, people don't tend to read them. Part of it is I think people don't know how to read papers. So what I'm going to try to do, rather than interpret this paper today, I'm going to, as I talk to you, I'm going to tell you how I think about this paper, like how to think about what they're telling you, right? So if you read anything, read the abstract first, because usually an abstract starts with an introduction, and here it tells you low back pain is a serious problem, lots of people. And then they tell you the aim of the study is they want to try to see if PEMF works for it. That's what they're doing. Then their method is they tell you what kind of study it is. It's a randomized, double-blind, sham-controlled, parallel group study. That means a lot to a scientist. And I'll try to unpack that for you, right? Randomized means that it's also blind. They didn't say that, but they're I'll explain.
Double blind.
Well, it's supposed to be double blind, yeah. And so, but they don't say that here in this little abstract methods section. By randomized, what they mean is they didn't decide ahead of time which person got a functioning device and which one got a sham. A sham device is a device that looks like it works, but it doesn't. You shouldn't be able to tell the difference. So you don't know if you've got a device that's really working or one that's just a sham, right? And that way you don't know whether or not you're in the group that's getting PEMF or you're in the control group. So randomized means you could be in either group and you don't know. Blind means that the subject doesn't know. Double blind means that the experimenter and the subject don't know, right? And here it says double blind, yeah. So I'm sorry. See, I miss things all the time. Sham controlled means that they have devices that work, devices that don't work. So double blind means this person doing the study and the people being studied, they don't know if they had a working device or not. It was random. Could have been either way. They could have had a sham device, that was their control group, and they were done in parallel. So at the same time people were getting PEMF, there's other people not getting PEMF. And then the other way you can do a study like this is a crossover, where you complete the first half of the study and then you switch. Everyone with a sham device gets one that's working. Everyone with a working device gets a sham. I personally love that kind of study. It's harder to do, it takes twice as long, but then you can compare. In each person, you can see, well, they were using the real device. Did they have an improvement? It might have been at the beginning or the end. And then while they were using the sham device, did they not have improvement? Did it get worse if they had gotten better beforehand? Or if they used the sham first, or did it stay the same and then they used the real device and got better? That crossover studies are the best. And that's the biggest deficiency I see in this study, is that it should have been, could have been a crossover, but it wasn't. And crossover, statisticians don't like it as much, but as a practical matter, as a clinician, you should love crossover studies, because by the end of the study, every individual in the study has had a chance to try the real treatment.
It does take longer, though. Just want to add that.
Harder to do.
Yeah.
And if you know only 10 people are going to read it, it's that much harder to justify.
Right.
But it's worth it. Okay. And I think it's most worth it to the people who volunteer for the study, because that way every person will know that
benefit.
Half of the study they will benefit. And then at the end, you can ask them, did you perceive any difference? And if they did, one of the things you can reward them for in the study is, continued access to something that they perceive gave them benefit, which is the way when you and I do studies, that's the way I would like to do them, because that's the most kind way to use test subjects, is that you treat them as a valuable and heroic person who's doing something really important for everyone. And you give them all a chance to benefit. That's the only way to do human studies, I think. But that's my opinion, and not everybody agrees. So then how do they measure this? So their method is how they give the PEMF. They tell you about that. Then they look at their endpoints. So they use the Oswestry Disability Index, ODI. And it measures, it gives you a number to tell you how disabled you are. Higher number means you have greater disability, right?
I used that in a study. It's an excellent
Yeah,
tool.
it's a really good instrument. It's
Mhm,
a really good instrument. And
mhm,
so that's good. I think that's a good part of the study. They measure it at the baseline. That means beginning. Where did you start from before you take any PEMF? Then after 6 weeks, and then after 12 weeks. All right. That, I think that was a problem. And we'll discuss that later. But I think waiting 6 weeks to take your first data point to see the effects is way too long. I think you should do it after one day, a couple days, a week. 6 weeks and 12 weeks, way too long, in my opinion. On the
mhm.
other hand, they carried it out farther. They carried it out for 12 weeks, which is a lot longer than a lot of studies, which will end at 4 weeks or 6 weeks or 8 weeks. They just end. So this was not a bad study. And then they conducted the analysis to see what the effect was. Then they tell you about the statistics. So the results tell you some important things, right? And first of all, they tell you the result of the study, but they say they started with 42 participants, um, either PEMF therapy or sham, but only 25 people completed the study. So almost half the people dropped out of the study. That should
Mm.
tell you something right there. Now, do you think that people who were using it and had a benefit would be more likely to drop out, or people who were using it and saw no benefit?
Well, I think it could be both. I found that in my study, one of the people that I was uh, studying for with PEMF, they got better and they just didn't want to continue anymore. They felt better and they said, I don't need to do
Right,
this.
exactly. And then if they start feeling worse, they'll go back to it. My sense is that a person who's getting benefit, especially
Mhm,
for pain, is
mhm,
much more likely, even though you're going to have people who quit no matter what. I think a person who's seeing a benefit is much more likely to stay with the study than
mhm.
someone who is not. And therefore, I think the biggest bias in this study is that the 42 participants may have been selected at random. However, their continuance in the study would be biased, because I do believe that although it's not 100%, people who are getting a benefit are more likely to continue on with the study than people who are.
Well, I would like to weigh in here and say that's not always the case. Sometimes people don't want to continue the tasks that they have to do to be in a study, and they're being contacted by people. They're having to answer questions, fill out forms. Sometimes it's because of that, and it's not whether they're having benefit or no benefit from the treatment.
There's no doubt about that.
Mm,
That's sometimes. And what I'm saying is that I think more often, if you take all of that into account, but a person is getting great benefit and relief from pain
mhm.
versus a person who's doing all the same things and getting no benefit at all, I think that second group of people is more likely to discontinue. The first group of people is more, it's my opinion. But this is the thing about science. People do not agree. There isn't a scientific community. There's rarely a scientific consensus on anything that can be interpreted differently. My sense now in this discussion is that I think there's more of a bias in this study. And maybe Stacey, I don't want to put words in your mouth, but maybe in your experience, it's not as bad of a problem, or it's equally distributed. Because if they're equally likely to discontinue, then there's no bias, right? So, but we don't know.
I
We didn't study that.
Yeah, I really think sometimes people they'll make a commitment, but then they can't keep the commitment.
That's for
And
sure.
sometimes it has nothing to do with the treatment or the device or the medication.
That's for sure.
And I think, 25 completed the study. So I think that that's substantial,
There's no question about it. That's substantial, and there's no question that this will have good findings. Uh,
especially over 12 weeks. It's difficult to have people do something consistently over 12 weeks.
You are correct. You are correct. So we both have a different view of this, but we both have looked at these things differently. You've had much closer clinical contact with people, so your opinion is probably more accurate than mine. And yet, as a scientist, I'm just sort of doing logically thinking, well, there's more of an incentive for a person to continue if they're benefiting.
Hmm.
It's like if you were paying, just look at it this way: if you were paying people $100 a week to be compliant in one group and not paying another group, the group that's getting paid is more likely to finish the study.
Hmm.
That's a bias, right? So you have to be careful about those things, right? And then the conclusion here, I like this. They just come right out and say this work shows that the device was safe and provides preliminary. They're saying it's preliminary because it's not a lot of people, right? That improves the function in patients with non-specific LBP. The other thing about this study is they talk about the ODI, the Oswald Street Disability Index, as their primary endpoint, but I actually think that their most interesting findings are on their secondary endpoint, which is their pain scale, 1 to 10 pain, right? It's my opinion. And then this one here, they talk about funding from
Just tell people the pain scale they're talking about is the typical 1 to 10 pain scale, 10 being the worst pain and 1 being the least pain, or 0 being the least pain, actually.
All right. Yep. So, and that's a very typical one, and they do that to doctor's office and everything, because you can't measure pain directly, so you have to ask people what their pain level is. This is the big problem in, for example, in veterinary medicine. You can't ask a cat how much pain it has. So they have all kinds of ways to tell how much pain animals in. And people, people have a little bit of an incentive to fib about their pain level. They'll often, to get out of work or to get disability, they'll boost up the level. But they find in studies on this that it's actually pretty accurate as far as anyone can tell. If the person giving you the answer is not incentivized to overstate their pain. So the other thing we want to talk about is that the funding comes from Aerotel Limited. Did you know that they're a company that builds PEMF systems?
No.
Okay, so one thing you always want to look for is it funded by someone in industry or somewhere else who has a bias? Like when I do a study, I own Micropulse, right? And I would like to see my business flourish. So I have a bias, and I just come right out and I say it. I own this, but this is the data I saw, and here's my data. You can look at it, and if you want to challenge it, that's fine. So it doesn't necessarily mean that a funding is biased, because a study's not necessarily biased because it's funded by a company. It's biased anytime, though, that there's money involved, but that includes NIH-funded studies. They're biased because if you're a professor, you need to publish. You need to get funding. And in order to get funding, you need to publish with positive results. So you have two huge biases in academic research. One of them is publication bias. You always want to publish positive results, not negative results. You don't want to say, we studied it and we saw nothing. Even though it's a very important finding, that only gets published 1 out of every 5 times that it should be published. The second bias is that professors have got to bring in money to pay their salaries. And so a lot of them make stuff up. And it's my professional opinion that there's more of a money bias in academic research funded by the NIH than the money bias from companies, because companies answer to the FDA. And if they distort stuff, they can be in serious legal trouble. So it's my experience, believe it or not, speaking as an academic tenured professor, I think that academic research is more biased than independently funded research outside the university. Okay. But that's my opinion. But you want to know, and not everybody's going to agree with me, right? So now we've sort of wrestled with, who are the people, and is it a reasonably designed study, and is it really obviously biased in any way? And I don't think so. I think there's little biases here and there. There's always going to be, in any study involving humans, there's going to be some kind of bias. You can't get free of it, but you do need to be aware of it, right? And so, okay, we've looked at these things. So now we're looking at it intelligently. And then the introduction is something you can usually kind of gloss over in a paper. They talk about the global burden of people with back pain. It's the leading cause of disability in most countries and most age groups. And it's about 1 out of every 3 adults worldwide has chronic pain, idiopathic chronic pain for 3 months or longer. 1 in 3 adults suffers from it. It is the largest health problem known to medicine. It is chronic.
Unbelievable.
It is much bigger than the next 5 combined. There's more people who will experience chronic pain than there are people who will have cancer, cardiovascular disease, stroke, type 2 diabetes, or AIDS. You can combine all of those, actually, and still only half the number of people who have chronic pain. So chronic pain is a big deal. It's not a small deal, right, in terms of number of people afflicted.
I just want to add that I researched this when I did my dissertation, And one of the things that amazed me was the ages of people experiencing the LBP. You might think it's just the elderly, but it's not. It spans all generations and all ages. So this is a chronic problem for all people.
You are absolutely right. I started having serious problems with LBP when I was a firefighter, when I was like in my late 30s, right? So when I was coming up on 40 years old, and I had had some back pain before then from weightlifting and everything, but I mean like serious crippling back pain since I was 40, is 17 years ago. So yeah, and a lot of people get it much younger, but very, very many people get it as they get older, right?
Yep.
So they say some very interesting things about lower back pain in the intro here, and I've highlighted them. Like typically, it's not possible to identify precisely why people have LBP. You can't see it on an X-ray mostly. If it's a really big injury, yeah, you can see it, and it's described as like, you know, non-specific low back pain, and it's not attributable to something that's known or that you can see on an image, like an infection, a tumor, osteoporosis, a fracture, structural deformity, inflammatory disorder, you know, anything like that that you could see. It's not necessarily there, and yet people can have debilitating back pain, and that's one of the great mysteries in medicine. We don't know. And the thing I love about this study, my favorite thing about this study, is they took everyone with, like, and you and I have done this too, right? Any kind of pain, you know, with a general sort of fuzzy boundaries. Here they're saying low back pain for whatever reason. They didn't look at one specific thing, trying to narrow it down to sharpen their statistics. They said, okay, all comers, we'll look at you, right? And they say this, which I thought was great, because that's the way pain studies need to be, is they need to cast a very broad net. Then you look for patterns, right? And here they talk about the things that everybody tries, and they tell you the truth. Heat, massage, acupuncture, spinal manipulation, yoga, exercise, cognitive behavioral therapy, and others. Those are great while you're doing them, but they don't give you substantial long-term reductions in pain or increased function. They just don't. You study them, they don't really get you anywhere for a long term. You get these short-term gains when you're in it intensely. Same thing with pharmacologics, and this is where Stacey knows much more than I know. You know, pharmacologics on this, not any greater evidence of effectiveness than these other treatments. That's why they compete. You know, pharmacologics versus, you know, meditation and yoga. It's just about the same, right?
Right.
And then, of course, the biggest problem is the opioid problem, because then you are adding an addiction on top of a problem that you're not improving with
Right.
that, right? So then they look at PEMF, and you know when we last time you and I were at a meeting together, remember that survey I gave out?
Yes.
Like the average person had tried like more than a dozen different types of things before they ever even tried PEMF.
Right.
So
PEMF seems to be one of the last ones that
it
people
seems
try.
to be, yeah, a treatment modality of last resort, which is a shame because it's totally non-invasive, right? It's
Effective.
something I would try before surgery, not after. Surgery is not really reversible, but PEMF is. You stop using it, right?
I don't think it's as well known as it should be.
I agree with you. That's one of the reasons we're talking about it, right? So PEMF has been shown in many papers to improve bone density and bony fusion for spinal fusion, but also other kinds of implants as well. It decreases postoperative pain and swelling. I've seen that in studies that I've at least started. PEMF is just, there's many, many papers on it. It's well over 1,000. Bill Pollock says there's about 7,000 studies that he knows of, and just shows all of these things are very effective. You know, it's effective for many things. So that's what they say in the introduction. Then in the methods, they usually tell you, okay, pilot randomized double-blind sham-controlled parallel group study to assess the effect of PEMF treatment on disability and pain for lower
What
back.
I really like about this study, because it's measuring disability and function, and then also pain.
I love this study for that reason. I really do. It's a good one that you picked. And then it does another really important thing. It's got clinicaltrials.gov. So it identifies the clinical trial. And that actually has a kind of a special meaning. In addition to identifying it as a legitimate clinical trial, it also says that you're putting your stick in the ground and you're saying that whether or not this works, we're going to publish it. So if we had a positive outcome or a negative outcome, we are committed to publishing the result. And that's a really good thing, because if it didn't work out and they don't want to publish it, well, they're already registered as a clinical trial and people can always challenge them. What was your outcome? And that's so it's kind of takes a certain amount of bravery to do that. And I think all clinical trials should be that way, because the results should always be published. And then they tell you about like institutional review board. That's the infamous IRB. Got an approval from University of Bridgeport, Connecticut. And they follow what's called the 1964 Helsinki Declaration, which is what I comply with, which means you're going to treat human beings like human beings, and you're not going to do bad things to them. And you're going to give them choices, and you're going to fully disclose things, all the important things that any child would tell you you should do when you're dealing with a person. That's what you say you're going to do. It's just amazing to me that people hadn't always done that, but they haven't. They, history shows, right? So then the study population, where I love this, the inclusion criteria were you had to be in pain of 4 or above on the numerical rating scale, NRS, had to be non-specific lower back pain, age 18 to 75. I love that. They didn't narrow it down to like a little tiny range, and then for females, they basically made sure they weren't going to get pregnant. That's also kind of important, right? Because then you're involving another person in the study who has not given their consent. And you don't want to do that because it's a safety problem, right? And then, they tell you about the recruitment of the people and everything. And that's important to know those things, but they tell you about them. We don't have to go over them. And then it tells you the study procedures, exactly what they did. They self-treat with the device for 30 minutes twice a week, at least 8 to 12 hours apart, or 2 times per day, different times of the day, 8 to 12 hours apart, every day for first 6 weeks. And then 30 minutes once per day, 2 to 3 days per week for the next 6 weeks. It's our maintenance dose. So they had an initial treatment dose, which was twice a day, every day for 6 weeks. And then a maintenance dose once per day, 2 to 3 times per week for 6 weeks. Okay, so
interject here. It's fantastic that they had 25 people that did that twice a day for 30 minutes. There's not a lot of people sometimes that would want to do that. So I think that adds to the study and the credibility of the study.
A lot of times when you're making a study, you say, well, for this device or whatever it is to really work, we need people to do a certain thing. But then again, most people won't comply with that. Either the medication tastes really bad, or the side effects are really bad, or the device itself.
Also add that after your highlighted area, it says a research assistant called the participants up to 3 times per week for the first week, and then followed up with them after that to make sure that they were complying and to see if there were any changes. So I think that's another asset to this study.
I agree with you. I just didn't want to highlight everything. I think most of what they wrote was important. And that was an important part, I remember, because they kept in touch with their test subjects very much early on. And you and I both know that increases compliance tremendously, because if people feel like they're being looked after and somebody cares and someone's keeping track, right?
Accountability.
So the next thing you need to know is, in the study, the device they used, it's an FDA Class 1 listed therapeutic device. So FDA Class 1 listed means that there was no FDA testing of it. The FDA just simply said, okay, that's a device and it falls under a certain category. And it's almost 100% certain, I haven't checked on it, that this is classified as a massage device, because the only Class 1 PEMF devices that I know of are massage devices. So nowhere at the FDA have they demonstrated safety or efficacy for pain, but they're listed essentially as an FDA listed device, where the FDA doesn't even want to hear about them, but they want to know that you're selling them. And that's for things like massage devices, dental floss, things like that. Okay. So it's not FDA cleared for pain, just because there's an FDA in there somewhere. People need to know that, because it's a little bit misleading unless you really know. And then it tells you an extremely low intensity electromagnetic field. nanotesla, 10 to the minus ninth. So that's a billionth of a Tesla. If you multiply that number by 10,000, so it would be sort of like 10 to the minus fifth Gauss. So it's extremely low level, whereas our devices peak out at like 200 Gauss, the ones that you and I use. So it's really low, but it's down around the range that I was using for, no, it's still below the range I was using for the study we did at NASA in the 1990s. But it's very low intensity and in the low range 1 to 100 hertz frequencies. Sham devices were externally identical, except they just were deactivated, so they didn't make a field, right? And then they tell you usual care. They just let people go on eating what they were eating, exercising the way they were exercising, doing whatever therapy they were doing. The only difference in the study was they either added PEMF or not. I like that because that's like reality, right? You're not asking somebody to eat, only eat organic broccoli or only, eat like roasted kale or something. It's like, yeah, it's something realistic. You're not asking for big lifestyle changes, and that also helps with compliance, right? I mean,
that's right.
So it's kind of important. And then their patient reported outcomes. They had two problems. I think that they talked about. One of them was somebody hurt themselves doing a sport. Another one was a woman hurt herself in a contraceptive device somehow. That's in here somewhere. That was patient reported. But then they also reported their disability. They took the survey again, and they took down their pain level. Presumably, they don't say this, but presumably they asked for pain at the same time of day every day, because most people have different levels of pain first thing in the morning versus, say, 5 in the afternoon. Right?
And that's what the NRS stands for.
Right. So yes, it's important that they do that kind of carefully so that they're comparing apples to apples, right? And then they tell you about the statistical analysis and how they did it. In the results, they tell you again that they screened 68 people, 42 were enrolled, and 25 completed the study. And then their primary endpoint, they go through here sort of like figure 1 shows you the logical flow for the study going through. And then, how they allocate things to people and their follow-up. And then the number that they analyzed was 12 in one group and 13 in the other. And, so 12 with PEMF and 13 with sham. So it doesn't look like that it was too much biased numerically. If you'd have seen about equal numbers for PEMF versus sham, and then towards the end, you saw mostly people with PEMF complying, then that means that the effective device had higher compliance, but you don't really see that. So it turns out that my concern is probably not important about the device active, whether it's an active device having a big effect on their finishing the study. So here they talk about safety. They had 2 adverse effects, one in the active group with PEMF who hurt himself or herself in a sports injury, and the other one in an inactive group due to what they thought was an intrauterine device in the sham group. So nothing related to PEMF seemed to cause any problems, as far as we can tell, right?
Right.
Then table 1 shows you their data. And I don't know, did you want to go through anything in particular on the data? Because I think what matters is sort of like when it's all kind of analyzed and graphed out.
No, I have some questions for you at the end.
Okay.
Yep.
So okay, then we'll just look at this. The discussion, they go ahead and talk about it, and they talk a little bit about how it reduces expression for inflammatory cytokines and other things. So the discussion will talk about things that they think are relevant to the data. And the discussion is another place where the authors can put in some of their impressions of the study. One of them was like right here, this work has several primary limitations, right? Although the study was randomized, double-blind, sham-controlled, the sample size was relatively small. And they think it was relatively small because of attrition among the enrolled participants. They lost like 40% of their participants. The most common reasons reported for discontinuing were symptoms not improving or no longer interested in participating,
Mhm.
right?
So
So
one thing, can I just add real quick, as a nurse, what I've seen is that sometimes people are expecting quicker outcomes for healing, whether it's pharmaceutical or devices. And sometimes people aren't taking enough time to let the devices or the pharmaceuticals or the natural modalities heal and help them. So sometimes people get impatient, and that can be a part of it.
well, I agree with you. I think that's the main issue, right? People are not very patient and they want things immediately. And
Or just a quick result, especially with pharmaceuticals.
you
So,
know, chronic conditions usually are the result of years or decades of doing something wrong.
yeah.
Stands to reason that it could take a long time to fix that, right?
Mhm.
So just a little bit of, here's their main results, right? They show the Oswestry Disability Index in figure 2, and then down here in figure 3, they show numerical rating scale, the NRS. So they're rating the amount of pain. They so just to describe what these shapes mean here, that's called a box and whisker plot. And so what it does is it's like at week 0, right at the beginning, what is everybody's Oswestry Disability Index score? So in this case, they all range from about 18 to a little over 40. And so the box, like a good way to look at these box and whisker plots is the very bottom is the lowest data point. The very top is the upper data point. It's the uppermost data point. And then the whisker sticking out of one end is the final quartile of the data. Like in this case, it's the upper quartile. The whisker down at the bottom, that's the lower quartile. So if there were 16 data points, there'd be 4 inside this whisker, 4 inside the lower half of the box, 4 inside the upper half of the box, and 4 in the upper whisker. And the middle line shows you the median. So this way of representing it with a box and whisker plot, and you can look this up on Wikipedia. They have a pretty good description of it. In Wikipedia, yeah, just go to Wikipedia and go box and whisker plot, and they explain this to you. So this tells you like how widely spread is the data, what's the maximum, what's the minimum, what's the median, and how are the data grouped towards the center, or are they sort of spread out more, right? So this gives you a sense of, this isn't really a Gaussian distribution. There's more people with a higher disability index, and then more spread out, fewer people, down lower, per level down lower here, right? So it gives you a lot of information if you read a box and whisker plot. And the interesting thing here is at week 0, they averaged, I don't know, about 35. And then by week 6, their disability dropped to maybe, 25, and then stayed there to week 12.
Right.
So all the magic happened in the first 6 weeks, right?
Mhm.
And that was the placebo group. But if you look, so the placebo group actually got better. If you look at the experimental group, they had a higher average disability, but look, they kind of overlapped a lot, but they had some pretty high disability. And the median was a little higher, it was almost exactly 40, and then dropped down to below 20, and it stayed there. So all the magic here happened in the first 6 weeks, right?
Mhm.
And also it looks, just visually, you can see it dropped from higher levels to lower levels on average. So
Right.
it looks like the PEMF device had a positive effect on disability.
Mhm.
I think that's great. And then if you look at pain, just pain itself, which should correlate pretty strongly with disability, certainly does for me. The more pain I have, the less able I feel, right? Pain, people, almost everybody was like pretty tightly grouped around the median there. That looks pretty Gaussian and sharp, right? So around 6.5 on a 10-point scale. And then after 6 weeks, it dropped to about a 3. And then another 6 weeks, it dropped to about a 2.
Mhm.
In the placebo group, if you look in the experimental group, at the beginning it was maybe 7, and then dropped down to about 2, and stayed at about a 2.
Mhm.
So people started with a little bit more pain, a little bit more spread out. All the magic happened in the first 6 weeks, dropped it from an average of about 7 to an average of about 2, and then it stayed there. That's what this data shows to me.
Mhm.
So what do you think about that, Stacey?
Well, I think this is an interesting way to show the results of a study. And I think that that's pretty substantial, that if you look at the experimental group, that they did have some relief and they had some outcomes showing improved functionality and decreased pain.
Mhm. And one of the other findings in this paper was that when you do a statistical analysis on it,
Mm-hmm.
see that these are statistically significant. That's what they say, is that the differences are actually real. They don't just look like it's a decrease. It's
Mm-hmm.
probably like 95% is their probability level, 95% likely to actually be a real difference. That's what they're saying. When they say something significantly different, they mean
I think
statistically
it's
significant.
valuable that they used both the pain scale and the disability scale.
I agree with that totally. I think that's because disability is just like, practical. Can you put your socks on, right? Can you do activities of daily living, right? I mean, those are really important things. And then of course, pain tells you a lot of things about your mental state and we
Right.
just
When
everything.
I was an ER nurse for 17 years, and one of the things that I found is that there are people that can still function and do things even when they're in a lot of pain.
Yep.
So that's why it's really valuable, is because it's showing disability and pain, both components.
Those things are correlated, but as you say, they're not perfectly correlated.
No, they're
Most
not.
people would have more disability when they have more pain, but that's
Mm.
not true for everybody. So yeah, so basically that's their result, and then they basically they talk about it and they have a conclusion. Usually the conclusion is entirely something that's worth reading. So if you're going to read 2 parts of the paper, 3 parts, you read the title, read the abstract, and read the conclusion. And they say they conclude that it is feasible to conduct a clinical trial of a PEMF therapy device. So they don't say that their this work shows that the device was safe and provides preliminary evidence for effectiveness in improving function. So they're not claiming that it's a done deal, that they've got really strong data. They're just simply saying, yeah, you can run this kind of study and you get good results. That's all
Right.
they're saying, is it's possible to do that with non-specific lower back pain, which I think is the most important part of the study. They weren't wimpy about it. They just said, okay, if you have lower back pain and you meet some basic inclusion criteria, like it's real pain, a 4 or above, and you're 18 to 75 and not pregnant, you're in. I love that part of the study because that's the way a study should be. It embraces human diversity. And what you
Mhm.
see in big pharma studies is just the opposite. Like when they first studied statins, they only studied people within an age group of like 57 and 58-year-old white men who had had one previous heart attack. They're really narrow. And they did that because they wanted a very homogeneous group so that they could easily get statistical significance. But if they opened it up to everyone of all genders and all ages and everything, you'd see that their effect would rapidly get smaller because you have to factor in all this human diversity, which I
Mhm.
personally find is very important. So if you've already factored in this human diversity and you still see a trend towards less disability and less pain, to me, that means something really important.
Right. One other thing I want to add about this study is that the paper was very well written. So there are a lot of studies, and obviously there are different authors. This paper was organized, it was systematic, it was easy to understand, and it was very well written.
I agree with that totally. I love this paper. So then they go through some other things that inquiring minds need to know about. Some of these things. These are the details that go back. They tell you about funding. It was from Aerotel Limited. Um, they tell you about authorship, like who was on it and how the who took responsible for it and what sort of standards they went to. International Committee on Medical Journal Editors is the standard level that they are complying with. They disclose that they received research grant support, which is totally important. And who's this guy, Mickey Scheinowitz, is a chief scientist at Aerotel. So he's a scientist at the company that makes these things for profit. That's okay. That doesn't mean the science is bad. Doesn't even mean that it's really biased. These guys want to know the answer as much as anybody. Now, a bad person is going to fake their data, whether they're in a university or whether they're in a company. And good people are responsible scientists are just going to tell you the truth. I don't see any reason to question this data. It doesn't show some kind of stellar outcome. It just shows a pretty good trend.
Mhm.
And I don't think they ever overstated anything. Then they tell you about how they comply with ethics guidelines. And then they talk about data availability, right? And that's important. The data is available for people to review. And then, of course, at the end of the paper, they give you a list of references, and they have, a pretty decent number of references, about 21. That's about the right number of references for a clinical study. 20 to
I
30.
reviewed their references and read some of those articles, and they use some excellent references for this.
Yeah, so they don't have low quality references.
It's one of the reasons I chose this article.
Yeah, exactly. So I think it's a good article, good references. The authors are good. There's a little bit of inherent bias, but I think they manage that fine. There's limitations to the study. They acknowledge there is for every study. There's some kind of a limit. They pointed those out. They acknowledged them, and then they gave useful, practical outcome measures, right? Disability and pain, both of them.
Yes.
I think that is excellent. So the only thing I would have done differently would have been a crossover. But
which takes a lot more time.
Would have doubled the length of the study and would have reduced compliance.
It does take more time. Can I ask you a couple of questions, Dr. Dennis?
Yeah, this would be a perfectly good time to do that. And you don't have to call me Dr. Dennis. I only require my parents to call me Dr. Dennis. Okay. This is because I have parent issues.
So can you explain to people the difference between the P in the results? It was P is less than 0.001 versus the P, which equals 0.135. And if you'll just explain that to people, what that means in the
P equals, okay. So P means probability. And that is the probability that it was just random chance. So a P of 0.1 means that you have a 10% chance that this is just a random outcome. 90% chance that there's actually some kind of a trend. Typical medical research, they use a P of 0.05. So that's 5%. 95, they talk about this a little bit in the paper too. So there's a 95% chance that it's significant and a 5% statistically significant. That means 95% chance that the probability is that it's not just a random outcome, but that it's 95% chance that it's really real. And a 5% chance that maybe it was just a random outcome. And so the lower that number is, like 0.001, that's a pretty high standard. That's like 1 in 100,000 chance that it was just random outcome. And right. 99,999 out of 100,000 that it was an actual thing that you see. And different fields of an actual real effect. And different fields of science have different standards. Like in medical and biological research, we usually use P less than or equal to 0.05, which is 5%. In physics, it's usually P, like if you're doing like astronomy or electrical physics or something, it's usually P equal or less than 0.000001, which means 1 in a million. Right? Because it's a lot easier to measure most physics things than it is to measure with all this human diversity and noise and non-compliance and all the other stuff. So the probability bar is much easier to pass for medical research compared to the sciences like physics. And that's one reason why when you get a physics result, you're pretty certain it's correct, because it's like a 1 in a million chance you just had a random outcome. Whereas in medicine, in biology, 1 out of every 20 papers that's statistically significant, that's 5%, should still be just random outcome chance. This is like 1 out of 20, you got a chance that you just have a randomly interesting result. Whereas in physics, it's more like 1 out of a million. So that's what that means.
Okay, so 2 more questions, Bob. What is the Friedman test of repeated measures, and why did they use that?
I am not a statistician, so I'm the wrong person to ask that question about. I think you could look that up on Wikipedia.
It wasn't my question.
Well, the Friedman test has to do with if you keep measuring something, you get a higher and higher probability that you're going to see something just randomly. So you have to do a test to make sure that by repeating your measurements, you're not just increasing the chances to have a randomly interesting result. So there's a lot of tests in statistics where, depending on how the data is distributed and how many times you measure it and other things like that, it will tell you, it will qualify your data in a way that you're not starting to kid yourself.
Yes, this is a fantastic book about statistics. I've read it several times. Discovering Statistics Using IBM SPSS Statistics by Andy Field. And that is a terrific book that explains that. And one last question is the chi-square test.
Chi-square.
Chi-square.
Same answer there. There's different kinds of tests you use for different things. And one of the jokes about statistics is, if you want two different opinions on how to statistically analyze a data set, ask two different statisticians.
Mm-hmm.
All right.
Mm-hmm.
I remember I had these very big, complicated data sets for my dissertation, and I talked to one statistician, but he gave me different answers depending on when I asked him. I took the same data set to him again to ask for elaboration, but he gave me a totally different answer. So statisticians really have trouble sometimes figuring out what in most cases, the data that you would ever see, they don't have any trouble at all. They know there's a certain test. So it is like the question, like, are you testing the means of the frequency of data? You know, is something at 65% statistically different from something at 32%? And that all depends on the number of items you're counting in each probability. Like, you know, if somebody's got if a president has a favorability rating of 65%, is he statistically different from another president who's got a favorability rating of 70%? And that actually depends on the number of people you ask in each group. And that's like a Z-score. So, you know, if you want to know the statistics, that's a whole discipline.
Yes, that's is.
There's no short answers. So if that's something you want to know, you have to commit to dozens of hours of study, maybe hundreds of hours of study.
What might be interesting for the authors of this study and this paper is if they did a follow-up, and to follow up with the patients and see how their pain levels are. Did they continue to use this device? Questions like that.
I agree with you. And you and I've talked about this before. The interesting thing is, a year down the road, have they gotten better or not? And there is evidence to think that PEMF can, if used properly and used long enough, it can have very far-reaching effects. Like in rabbits, they were finding that for young rabbits that had like hematomas induced in their ears, it was helping those heal in a way that they wouldn't have healed. It's helping those heal, and that healing lasts their entire lifetime.
Using PEMF?
Using PEMF, there's a paper on that. Yeah, it's one of the very few long-term PEMF studies. And this is why I've always said to you, you know, the thing is, to study it longitudinally would be the most helpful thing for PEMF. It's like, you know, does it help you a year in, 2 years in, 10 years down the line? These are great things to know, but generally speaking, people cannot get funding to do studies like that. You cannot. There's only a few really long-term studies, like the Framingham study they did, the cardiovascular one that's all NIH funded. But these are like whole institutes that are set up, and people run their entire careers there. And they'll study cohorts of people from like the age of 15 until they're 65 or something like that, and try to stretch out as long as they can. But these are extremely rare. They're very expensive. It's very difficult to do. And imagine trying to exert compliance over a study for 4 decades. Imagine that. So they basically have to really cheerlead it. They have to really make it like, you know, a big identity for people who live in Framingham, Massachusetts is, you know, hey, I've been in that study for 35 years. You know, it's a big, like a cheerleading kind of a rah-rah kind of a thing. You know, it's like this exclusive club that nobody else can be in. And it takes that kind of psychological manipulation to get people to just keep track of what they're eating, you know, and share their health status regularly enough that the study is useful. And yet, the few of those, the very small number of those studies we have, they're unbelievably helpful for things like long-term effects of exercise and nutrition on cardiovascular health and all that stuff. Those are really great. I was going to say, actually, another thing I was going to say about statistics is that statistics is one of the largest areas where people have found that these biomedical papers fall down. In particular, there's a guy named Ioannidis, Greek name, Ioannidis, and he's a statistician, and he has a paper that's titled, "Most of what we know in science is wrong." And he makes a statistical argument that strictly based upon the statistical tests that are used in typical biomedical papers, their conclusions are incorrect based upon the fact that they use the wrong statistics. So it is very sort of questionable. Are you using the right test? Did you use it the right way? If we look at table 1 here, look at their p-values, sham versus active. Their p-values were pretty high. So that's almost 0.75. That's like a 75% likelihood of being the same, 82%. So these are supposed to be about the same because they're trying to make it all equally distributed ages, equally distributed marital status, right? And then like the ODI means, the mean values for the disability indices, they were basically the same, and the means for the numerical rating scores were 0.661. But if you're looking for differences, you want these numbers to be as small as possible. Like for it to be able to say it was statistically significant, you want to. This was their baseline. So this table is saying these are basically the same groups, because this 0.823 means that it's 82.3% likely that they're basically the same groups when you're looking at, are they married, single, or divorced. Here, the racial differences, there's a 17.5% chance that these groups are basically the same. But you had more white groups and more white people in the sham group, which struck me as somewhat unusual. But they weren't able to completely randomize it because they just didn't have enough people.
Right.
So up with like more black people got active devices than white people by almost twice as much. More white people got sham devices by more than twice as much. These are interesting things to know. So in these cases, you want these to be as close to 1 as you can get. And this is the best one.
We need more studies like this, and more studies on PEMF, and more studies for pain using PEMF. And I wanted to tell you, thank you so much for explaining the paper to myself and to other people. And next time we do this, one of the things that I would like to do is just bring in a little statistics, and I can do that and explain some of the statistics, because I found with some of my colleagues, that was the area where we had sometimes some confusion and difficulty was with statistics, and it's an important part of a research study and a paper.
It always is, absolutely. And so that's something that would be worth delving into. My main thing is, do people know how to think about these papers? And in the end, people will want to know, is there a significant decrease in disability and pain? And it looks like there was a statistically significant decrease in pain.
There was.
For 6 weeks, and probably disability with the PEMF in the first 6 weeks. And it looks that way, and I think the study was great, and I don't have any real reason to question the data. Different statistical analyses might tell you differently whether it was statistically significant or not, and that's a separate issue. But yeah, basically I'll just stop share here, and I think that's it. And if anybody has any questions, you can type them in, and we'd be happy to try to answer them. Other than that, I think we're basically done. What do you think, Stacey?
Thank you, Dr. Dennis, for your expertise, as usual.
All righty. And we hope to do this again soon. Thanks.
Thank you.